So what do you do in second line?
So now it gets a little bit complicated. If you look at the NCCN guidelines, there are 7 agents listed. Now, we have to pay attention between, is it from the NCCN guidelines or is it based on randomized phase 3 data? And that's where the different categories come in, category 1 versus 3. So in terms of TKI-based or anti-VEGF-based second-line plus agents, we have regorafenib, cabozantinib, and ramucirumab for patients with higher AFP than 400 in the second line based on category 1 data. But we also have checkpoint inhibitors, nivolumab and pembrolizumab as category 2. And actually, sorafenib is also listed for patients who progress on lenvatinib. Now, when it comes to choosing the treatment, really, if you want to be going by data, you can see what was the eligibility criteria in the respective trials and kind of let those guide you. For regorafenib, which was the first TKI that was approved in the second line setting based on the resource trial, those were only patients who were able to tolerate sorafenib, as defined by at least 400 milligram a day for the last 3 weeks or 4 weeks of treatment before progressing. Those patients were randomized to placebo or full dose regorafenib 160. And that showed positive outcomes in all primary and secondary endpoints, overall survival, progression-free survival, and time to progression.
So if anything, in other words, what you're telling us here is that if I'm not mistaken, also it's a requirement by the approval of the regorafenib that prior exposure to sorafenib is necessary and should have been well tolerated. In other words, if patients don't get sorafenib beforehand, they are not technically eligible for getting regorafenib, correct?
That's correct. And technically, even if they received it and had toxicities and came off, they wouldn't be eligible to go on resource.
Fair enough. So what are the other choices besides Rego?
So the second one is cabozantinib, a combined VEGF-AXL inhibitor based on the Celestial trial, large study of second-line plus. They must have all had received sorafenib, independent if they progressed or were intolerant. But there were about 20-25% third-line patients on that trial as well. Not a lot of exclusion criteria in terms of disease volume in the liver, portal vein thrombosis, etc. Primary endpoint was overall survival. It was a randomized trial of 60 milligram of cabozantinib versus a placebo. And again, that was a positive trial with a hazard ratio of 0.76 for overall survival superiority, 10.2 months. But importantly, for the first time, we see with Cabo in the second line setting, despite second and third line patients, PFS that extends beyond 5 months, 5.9 months in all comers. If you look at second line patients only, it actually goes up to 5.5 months. So that clearly put it as a category 1 in second line plus after sorafenib. And more recently, based on the REACH-2 trial, we have ramucirumab, anti-VEGF receptor 2 monoclonal antibody, which was tested in patients with an AFP of 400 and greater. And based on a randomized placebo-controlled trial. And again, that trial also showed for patients with high AFP, overall survival is improved with the addition of ramucirumab versus placebo with a significant improvement of progression-free survival.
So we have in second line, quite amazing, as you said, we have regorafenib with prior exposure to sorafenib as a condition and, if anything, tolerance of sorafenib, and at the same time, good tolerance and progression on sorafenib. Number 2 is we have cabozantinib, which can go even a third line, as you mentioned. And thirdly, we have ramucirumab, but the requirement of alpha-fetoprotein. Let's talk about the other options in second line, and let me turn to Amit and tell us, Amit, and of course, we have to talk about immunotherapy. So what are checkpoint inhibitors there?
Yeah, so checkpoint inhibitors essentially are a medication that can help essentially use your body's immune system to actually fight the tumor. So, a tumor basically will express PD-L1 that will then ramp down your immune system. It's a way for the tumors to escape immune surveillance. And these medications are basically able to ramp up your T-cell response and actually fight the tumor. There's been 2 that have been evaluated in terms of HCC, nivolumab and pembrolizumab. Both actually showed very durable and deep responses, about 15 to 20% in large phase 2 studies. Now both have gone on to phase 3 randomized trials, and unfortunately both of those phase 3 trials did not replicate or did not provide a survival benefit compared to the comparator arm. But one thing we can say is that I think both these trials, as we've talked about before, I think have advanced the field in terms of really showing responses, deep, durable responses with systemic therapy.
Fair enough. So again, we have, in addition to what we heard about the TKIs, we have also 2 checkpoint inhibitors that are approved currently, at least in the US, in second line, despite its limitation based on phase 2 data, as already prompted us to make sure we mentioned that, Farshid, in the beginning, being nivolumab and pembrolizumab. Despite the phase 3 trial, both of them were negative, being the nivolumab versus sorafenib in first line, and same time pembrolizumab versus placebo in second line. I'm going to go back to all that discussion, but one more important point, which, by the way, I'm sure we're going to have colleagues or even ourselves we might ask the question, and I'll go to Riyadh for this. Recurrence with an adrenal met, that's it? Can't you guys do anything with IR for this adrenal met?
Well, you'd be surprised what we can do. Sure. Yeah, thanks. So there's no doubt that the manifestation of metastatic disease with HCC is diverse. You can have bone mets, lung mets, et cetera. So an adrenal met is a unique form of metastatic disease, and one of the ways that we can treat some of these sometimes is with an ablative therapy, usually a cryoablative type therapy, if it's accessible. So we've seen some of that stuff. I think there's been some radiotherapy, SBRT, that's been applied to these solitary lesions as well. Those tend to be rare, and I think those tend to be the patients where that's the only site of disease. And actually, in fact, in some patients, if the time from sort of disease treatment to recurrence is long, they've been resected because they're better biology patients. So in fact, this is an opportunity to think outside the box in the right patient. In terms of applying these types of options. So there are options for these patients. The reality, however, they're still sort of metastatic disease. They're BCLC-C, and systemic therapy is still the gold standard. But certainly, you know, when you manage patients, they're looking for individualizing care, as you mentioned at the beginning of this broadcast, is that we need to individualize that. And there are patients that sort of presented very late that went on to resection, went on to ablation, and lived even longer. So certainly, this multidisciplinary tumor board team is what allows you to sort of have this kind of discussion.
That's why I really very much like to work with Dr. Salim. We're good friends, but at the same time, I'm always fascinated, and this is really what's important in regard to multidisciplinary team, is really understanding what are the choices that are on the table, not only from your own specialty, but from all other specialties. And same way we have seen, and I like very much the thinking process, is that, yes, we can do technically what's need to be done, and of course we do acknowledge that, but number two, it's fascinating. And look at the attention in regard to the biology is we have to wait rather a little bit of a long period of time to really prove that there's the only disease that's still there, and then we can consider a local approach on top of the the systemic therapy. But this is really will require a close and long observation per se. More importantly, Dr. Salim is talking to us a little bit from a rather historical perspective as well, because remember, as Farshid just mentioned to us, we were just at like one choice a few years ago, and now we're at 7 choices. So no doubt that things are opening up in regard to more opportunities that you can help patients with. And I would say usually what I tell patients is it's good to keep everything on the table, and we never say no to anything. But at the same time, however, there is a certain methodological and systemic way to really think about the process. Exactly as Dr. Salim, despite that, yes, technically he can take care, and I'm sure he will do an excellent job in regard to a adrenal met, but nonetheless, systemic therapy is the essence over here in regard to the treatment management of this patient.